Okay guys, we're going to start recording here.
That is the natural and great.
Alright, you guys ready? We left off on traumatic brain injury on Monday, or excuse me, on Friday. When we get to the clickers, I'm hoping to get to there at the end of today. We'll switch over to my computer. There's some type of configuration thing going on with this computer. It shouldn't affect the recording at all, but it'll help you guys, so you guys can actually click your questions. Did everyone get one up here? I'll not get one. Okay, so we finished up with CVA. Not that we're completely done with it, because a lot of this is related. CVAs have a lot to do with your head. Obviously, that's where the stroke is occurring. And in traumatic brain injuries, you're going to see a lot of the same problems depending on where the impaction is at, from like an accident or a fall. With traumatic brain injury, it just means that there is a blunt or a penetration to the brain or to the head. Usually you think of traumatic brain injuries when you think of car accidents, very common, or severe sports injuries, or an older gentleman or lady falling on their head. That can be a traumatic brain injury. When you think of spinal cord injuries, a lot of these can be related as well, because if you think about how your brain is affected, it affects your spinal cord as well. So just because you have a brain injury does not mean that your spinal cord is not affected. Okay, so look at the whole picture. You might have cervical fractures because it's so close to the head. Most of traumatic brain injuries, this is just based on studies. If you think about a young adult, most of the time it's going to happen in the summer and spring. That's when people are out and about on the roads. Four-wheelers, just different types of ATV. That's what you're going to see the most common. Nights and weekends, what happens on nights and weekends? Drinking. Okay, that's the most common time that people don't have the best judgment. And so you're going to see most of the time happening on those times. And then, sorry guys, Matt, males are more affected. They have that riskier demeanor, and that's why they're affected more. When you have a certain type of traumatic brain injury, you will have your normal functioning disrupted. Whether that be a small concussion, when you just mildly concussed your head, or a severe one where you're in a vegetative state on a ventilator. So you will have some type of functioning disrupted. You can have a direct blow where your head actually hits concrete or hits something directly, or you can have something like whiplash where you don't hit anything, but it's the force or the shaking inside your head that causes the injury. You also can have a primary or secondary injury. Primary is the actual injury that's occurring. So if you have a hemorrhage or some type of fracture in the skull, the secondary is what happens after that has happened, like intracranial pressure that's increased, swelling in the brain. Those are things that you can think of when you happen because of the injury. Okay, so that's the secondary part. So you can have secondary injuries. Okay. So types of things that you will see on traumatic brain injuries, you will see some type of loss of consciousness, not always, but if it is severe enough, they will lose consciousness. If there is swelling in the brain, you can see seizures, and that deals with the disruption of swelling in the brain and pushing on certain types. If there is loss of consciousness, you might see some drowsiness after, some confusion, and that is normal after. Well, not normal, but you will see it happening. If they do have some increased swelling, they will get really restless. Most of the time they have that sedative effect at first, and as the swelling starts to improve or increase, you will see them get more restless and irritable. And those are signs that you can think of that could be for intracranial pressure increased. Like I said, confusion. They can have bruising, maybe not just on the face or in the head. They can actually have bruising on the brain, and you have to see that with a scan. So every time there's any type of head trauma, they will have a CT scan initially, and then potentially an MRI if it's severe enough. Okay? Double vision, having vision changes, trouble walking, those are things that you can see as well. We will always assess pupils to make sure that they're not fixed or dilated. We want to make sure that they're perfectly round and that they are reactive. This is something you will do frequently in any environment, especially if the head is affected. You can have different types of vital signs. I wouldn't get too caught up on brain injuries for their vital signs, because you can have two different types of shock. You can have hypovolemic shock, you can have hemorrhagic shock, or you can have neurogenic. So not all the time does it correlate. So that's why I thought you could have bradycardia and hypertension. That's something called the Cushing's triad, which they have a traumatic brain injury from increased swelling, or they can have hypovolemic shock. So I'm not going to get too picky unless I specifically tell you it's because of hypovolemia or because of the Cushing's triad. Okay, and we'll talk about that in a bit. If there's any cerebral spinal fluid leak, remember meningitis, that's a concern, infection. If there's an open injury where it's actually leaking outside the brain, we can have nuchal rigidity, which just means your neck literally does not move as well as it should. And so we can test that with a couple different tests. And we will do that if we suspect if it's an open injury. Okay? When you think about injuries to the head, we have two different types. You have an open and a closed. They're pretty self-explanatory, okay? You may think that open injuries, head injuries, are more intense or severe, but actually closed head injuries are worse. And the reason for that is because when you have an open head injury, you actually might be exposing some type of dura or also some type of cerebral spinal fluid leak coming outside your head, which, yes, that's important, and you have a high risk for infection. But with a closed head, if you have an increased amount of swelling, there's nowhere for that swelling to go. And so if that swelling increases, you can die, and it is detrimental to their life. Okay? So, no head fracture is good. But if we were to pick one, open would be better. Okay? We at least have something to work with. You can classify them as mild, moderate, or severe. And the way we do that is their Glasgow Coma Scale. You remember what's good for Glasgow? 15 is good, 3 is the absolute worst. They'll get 3 points just for being alive. Okay? So obviously, if it's less than 8, you think about intubating that person, and they are in an almost vegetative state because they're not responding. Okay? And then loss of consciousness. If they are not actually alert and awake, we can assume that they have severe brain damage. Open injuries are also called compound. If you see that interchanged, they are the same thing. Okay? Did add that on there. Okay, so with open head injuries, we're going to talk about them first. Remember, that's when you actually have an exposed dura mater where they can leak cerebral spinal fluid and the brain can be exposed. Usually those are fractures that when you are hit by some type of blunt trauma, it actually cracks the skull and you have some opening there. You can have a linear fracture, which is not as severe. They're very common. Think about how hard your skull is. Really hard to actually put a hole through your skull. Okay, they usually use drills. Think about how they do surgeries. So if you're actually doing a depressed fracture, which is severe enough to open up into that dura mater, that's a pretty severe blunt trauma. With linear, it's literally just a line. That's all it looks like. It's a line fracture, but they can have little particles of the skull get broken off into the brain, and so they have to go and debride those and clean it up because they have a high risk for infection because it is an open injury. Okay? So just because they have a linear fracture doesn't mean they just let it heal. They still might have to go in and clean it up because there could be some fractured skull kind of particles moving around. With depressed, that actually means that you have a hole in your head. There's a depressed part of the skull, and that actually could puncture some of the areas and cause a lot of swelling. With open head fractures, we really worry about the intracranial pressure and making sure that you're not having increased intracranial pressures. And we'll talk about how you look at those, when you know they're actually increased, and then which ones they look forward to and which ones they're there. But with depressed, it's definitely worse, even though they're not as common. It's actually very hard to put a hole, like a divot in your head. Okay? It's very thick and it's very hard to do. I did add this picture. I don't know if you have it, if you printed a week or two ago. Just kind of gives you a visual. You can see the linear, which obviously is the least invasive, but it can still cause infection because there is some opening there. Depressed is also a little more severe open head injury, and they have to go in and clean that up. Because if you think about all these little cracked particles here, it's just going to be floating inside your brain there, and that can't be staying in there for too long. Compound is another name for open. You're completely exposing the entire area, and that does happen, and those people most likely will have craniotomies, or they'll have to go and get other bones from the part of their body to put that over their head, okay? Because that part of the skull is just shattered. There's no way to replace that, or no way to bridge it. They actually might leave that open. They'll clean it all up, and they'll leave it open for a while. So if the swelling is bad enough, which if you're that bad with a compound fracture, they'll leave it open so the swelling has somewhere to go, okay? And so they'll definitely be in the ICU for a while. Okay, basilar skull fracture. Have you guys heard of this? This is what they tell you for like NG tubes. If you suspect a nose fracture or a basilar skull fracture, to not put the NG tube in, or potentially don't nasal intubate somebody if you suspect basal skull fracture. And the way we know as nurses is the battle sign and also the raccoon eyes. You see any bruising right around the eyes or right behind the ears, which is hard to do because you don't think about looking behind someone's ears. But if they have a traumatic brain injury, a fall, it doesn't have to be traumatic as in a car accident, but a little old lady falls and you see a little bruising behind your ear, you may suspect a basilar skull fracture, which is really hard to determine because they usually don't have that many side effects from it. Okay? And so when we see this, we suspect that the skull fracture is inside the brain on the base. So if you think about your nose, directly behind your nose. So it's pretty low in the brain. So obviously they're not having trauma on the outside here. It's a lot more on the inside. Okay, so it's hard to determine. But if you see those signs, you suspect a basilar skull fracture. And it is a serious thing, okay? Those fractures in there, the little particles, can actually break away just how you would in a normal fracture, and it can cause infection. And if you see any type of drainage coming out of their nose, we need to test that because that can be cerebral spinal fluid leak. And the way they do that is they put it on a piece of white tissue paper. If you see like a yellow halo ring around that drainage, whether it's hemorrhage or just clear drainage, you'll suspect that it is a basilar skull fracture. Okay? And so they can do a glucose test, which isn't as good as the halo test. You will actually see the yellow ring. I've never physically seen it, but I've seen pictures and it's pretty prominent. Okay, so yellow ring. That's what the halo test is. Since it is kind of in that general region of your nose and the cranial nerves all come together, you can affect your 2, 7, and 8 cranial nerves. And those are your vision. Let's see if I can show you. Your facial is 7, and 8 is your hearing. Okay, so all right there in the middle. You definitely can affect those. And if there is cerebral spinal fluid, we'll suspect a hemorrhage, or excuse me, an infection or meningitis. Might be potential risk for those. Okay, so those are our open ones that we were concerned about. Now we're going to talk about the closed. Remember we said the closed was more severe or potentially more life-threatening due to the swelling. If you think about closed head fractures, you may not see right away the symptoms that you might see with an open head fractures, but there could be over time, maybe an hour or 5 hours later, you see more and more symptoms. Your most common thing that you're going to realize or see in your practice is a concussion. They can be as mild as no loss of consciousness or as severe as they are completely in amnesia, confused, they have headaches, or puking, vomiting. That's things that they might be in a more severe state. If they do have a loss of consciousness, they must come to the physician or ER. Most people don't know they've had a concussion. That's the reason why I say if you don't lose consciousness, you don't have to come to the doctor, because most people didn't know they actually had a concussion. If I got a really hard hit on the football field, may have felt a little funny, but it came back and they were fine, they're probably not going to go to the doctor or rush to the doctor. But if you lose consciousness, you should come into the physician to be evaluated, especially if it's happening repeatedly. They can have a little short-term memory loss, and so that's why when it does happen, we do ask, where you are, what's going on. They do ask those simple questions for those people. A contusion is a fancy word for a bruise, essentially, on the brain. If you have a coup or a contra-coup bruise on the brain, it deals with like the whiplash. If you've ever gotten true whiplash, your head whips back and forth in a true whiplash. Your brain can slide forward or slide backward, depending on which way something hit you from front or behind. Coup is when your brain slides forward, and contra-coup is when it slides backward. Okay, and we'll look at a picture so it looks a little easier to visualize. But it's basically you don't have any physical trauma to the head. It's more the movement inside. Your brain does move back and forth. Okay? Again, it can be mild or severe. You might just have a small whiplash where you get hit on the football field, or you might be in an 80 miles an hour crash and come to a halt. And that could be a really severe whiplash. Okay? So it definitely depends on what's going on. A diffuse axonal injury, this is probably the worst of all the closed head injuries. This can result in a vegetative state, usually because of high-speed crashes. And it's actually the axonals inside your brain, deep within, and they're actually damaged to the point where they may not come back. Okay? These people are usually in a coma. They might come in and out. They might be in there forever. But it is the worst, and it has the highest risk for bleeding and also for swelling inside the brain. Lacerations, those can be little cuts inside the brain. Think about those skull fractures, the bones. They can be cutting the brain when it gets shattered inside. And those can definitely cause hemorrhage from poking or potentially lacerating the brain. And you will see inflammation and swelling with that as well. The key for all these is intracranial pressure changes. Okay? The nurse is constantly worried about intracranial pressure changes from the head injury to begin to when they are actually healed. They're constantly worrying about it. Because usually it's not the injury, right? It's not the primary injury, it's the secondary injury that kills someone. The intracranial pressure changes, the swelling, the hemorrhage. Okay, so here's our coup and contra coup. If you think about someone getting punched in the face with that boxing glove, they're going to have impact from the front, right? If you're getting punched, their head might slide forward. If you think like this, the brain's going to go forward, but the head's going to go back. Okay? It's the opposite. If they got hit from behind, it'd be the complete opposite. Hit from back while your head goes, or your brain goes forward. Okay? So bruising is all that is. See how it's on the back, contra coup, and then coup's on the front. And usually with that, it's time. They can cause increased intracranial pressures and hemorrhage, but usually the point is we have to slowly get back to their normal, and that can take weeks. Okay? And we'll look for intracranial pressure changes. We talked about how the head kind of moves when you get pushed back and forth, but acceleration injuries, when you think about a type of force, let's say you got hit in the head with a baseball bat, someone accidentally hit you in the head, that would be an example of acceleration injury because your head is not moving, and it actually hits you, and that's why it actually causes your the brain to potentially move. That can be an acceleration. Deceleration is when you actually have a moving head and it stops on something hard like concrete. Your head is moving until it hits the concrete. That's a deceleration injury. You decelerate very quickly. And then the coup contra coup. That's a type of force as well. That's the whiplash. Actually, is what that is. Okay. And then there's another picture too that shows it. You get hit from behind. Potentially, your head can move different ways, and the forces can go the opposite. And usually, it's a bruise. It's just a fancy word for a bruise, or coup and contra coup. Okay, so that's our primary injuries. That tells you why the actual injury is occurring. And now we have a problem, right? We have a closed injury or an open injury, and potentially we might have some secondary problems because of those primary injuries. The number one you're going to see is intracranial pressure changes. If they have a severe head trauma, they will go to the neuroacute part of the hospital. They may potentially have a pressure inside their brain monitor that monitors at all times, or they'll just have frequent neural checks, if it's not a severe enough one, to make sure that they're not having increased intracranial pressures. So the way intracranial pressure works, if you think about in the brain, you have so much fluid in your brain, right? Connected to your spine. Think about your entire brain going down your spine. Your cerebral spinal fluid is located in your brain all the way down your spine. It will compensate for each. So if you have a very big swelling in your brain that's causing pressure, that cerebral spinal fluid will go down into your spine to compensate. Okay? It'll reabsorb back into the spine. It can't do that completely because you need to have that cerebral spinal fluid in your brain. So even if you have a severe enough swelling, you still have to have some cerebral spinal fluid in the brain. If you don't have a lot of cerebral spinal fluid in the brain, that can actually cause your blood circulation to go down and your brain vasodilates. So now you don't have blood perfusion, your cerebral spinal fluid is low, and you have increased swelling. So as it increases, that's what's actually occurring. I don't know if some of you have been across NCLEX questions, but a lot of people will be on ventilators because their carbon dioxides are so high with intracranial pressure changes. If it's severe enough high, your carbon dioxide will go through the roof. And they'll put them on ventilators, one, because they need it. They can't breathe. They're hypoxic. But they're in an acidosis where their carbon dioxide is so high that they'll hyperventilate them. Remember when your CO2 is so high, it's because you're not breathing as well? Okay? They hyperventilate them on the ventilator and blow off all that CO2 and can decrease the swelling. So it's very common in these patients to be on a ventilator and to hyperventilate them because their CO2s are so high. Okay? Once they get back down to that normal range of CO2, they can obviously back off on the ventilator and not have as hyperventilative states. Like I said, it's a vasodilation, so their venous supply of blood is not as great up there, and you are going to have some tissue perfusion problems. Most of these people have very high blood pressures. Okay, so if they're on intracranial pressure readings, and for some reason their blood pressure is through the roof, but how do you really know if they're perfusing their brain if they have a lot of swelling? You really don't. You have to rely on medications to help you circulate the blood. Because you can have a high blood pressure thinking, oh, they're perfusing, right? Getting enough blood everywhere. But since the swelling's so bad on the brain, they might not get much blood returned to the brain. For secondary responses, it is the #1 cause of death. Just because you got a head injury doesn't mean that's what killed you. It's usually the swelling after. Okay? Okay? Hemorrhage is another common one. It can be anywhere from a bruise to an actual hemorrhagic stroke. If you think about the people that hit their head hard on concrete or fall from a bathtub, those are the people that are going to have hemorrhages because it's a severe blow. And if you have all that blood leaking out or trying to go somewhere, escape, it's not going anywhere. Okay? Sometimes doctors have to go in and actually escape that blood inside the brain and make sure that it has somewhere to go. Because you're going to have swelling on top of this and now blood. Your brain can only hold so much. And so they might have to evacuate the hematoma if it's that severe. I'm sure you've heard of these three things: epidural, subdural, hematoma, and intracerebral hemorrhage, usually because of falls. Very common in the older population, the hematomas. Epidural is probably going to be your, not necessarily most severe, but probably most common. If you think about the layers of the brain, your dura is what covers the brain. It's the sac that goes around it. This is going to be on top of that dura. It's in between the skull and the dura that covers the brain. Not in the brain, it's on top of the brain. Epi, right? On top. So when you have this, there can be times where you go in and out of consciousness because it's not directly inside the brain. And that's actually worse. If you notice your patient goes in and out of consciousness and eventually will go in obviously a coma if it's that severe of hemorrhage. But if they're going in and out, it's a neurological emergency. Okay? Usually these people will get CT scans right away. We'll find that it's an epidural hematoma, and we'll probably intubate these people. Because if the swelling gets severe enough, they will probably lose consciousness for indefinitely until we figure out what's going on. The blood that's accumulating is arterial blood because it's wrapping around the skull there. So if you think about the blood that's coming through, it's your arteries. This is a very fast thing. That's why they lose consciousness right away. So if it's within the first hour or two and they're having this problem, you can assume epidural hematoma. If it's happening 4 or 5 hours later, you might suspect the subdural because that's a little bit longer and it doesn't take as long, or it takes longer to come. So if you see this happen within the first hour where they go in and out of consciousness, you can assume epidural hematoma. You can kind of see a picture of the dura and how it works. This is the epidural hematoma. It's outside the dura here. There's an actual skull fracture here, but they can be in between the skull or like right on top. It doesn't matter, it can be anywhere. And this is your actual skin on your head. So it's the outermost one. Okay, but yeah, you can, yep. And that's accumulation of blood too. Because it's a bruise. Think about how a bruise is on your body. Same thing. They had some skull fracture in there. You won't always have skull fracture, like the actual particles breaking. That looks like a little more severe one. But you can just have a minor linear fracture and have the blood accumulate on top. And then we'll look at subdural. We'll come back to this so you can see it. Okay, so subdural has a higher mortality rate than epidural, but it takes a longer time to come. Okay, so if we suspect that they're having any type of hemorrhage or bleeding, it's probably going to be epidural if it's right away. But if it's taking 5-6 hours, it's probably going to be subdural. It takes a little longer. And it has to do with the swelling of the brain. Swelling of the brain does not happen in an hour. It's going to happen over 6 to 12 hours. And then it's going to start getting worse and worse and worse. So usually it takes a little longer. These type of bleedings, it's a venous blood instead of arterial blood. That is a lot of the difference as well. If you think about the artery on the outside and the venous on the inside, that's why it's a difference. So subdural is on this side of your dura. Subdural, underneath the dura, okay? Makes sense. Okay. And then your intracerebral. That's actually inside. What's that?
Will they drain?
For like intracranial pressure, yep. You can get rid of any intracranial pressure in the brain, anywhere. It can be in the ventricles, can be outside the dura, inside the dura, anywhere. If there's pressure and swelling, they can escape it through a canister that goes in. And we'll look at a picture of that too. Intracerebral is actually inside. It can be in the ventricles, but most of the time it's like in the space of the brain. And that usually happens from blunt trauma, same way. If you think about intracranial pressure changes, this is probably going to be your most detrimental. A lot of the time the swelling goes in there, so it has to force its way out instead of just one portion of the brain, like an epidural hematoma is in one spot. this is going to press everywhere out because it's inside the brain. So it can have problems escaping that pressure. Go back to the picture. So this is actually inside. If you think about this expanding, it's going to expand everywhere, right? Because it's pushing everywhere out. This is just going to have one little area, or it only might affect one part of the brain. Subdural's right here. It's going to be below the dura. This is the dura right here, this line. The like coating overside the brain. Yep, it's going to be right below it. So actually underneath that dura. So it kind of is in the brain, but it's underneath that little sac. Okay, it's not quite inside the brain. A lot of these come together very similar things, and that's okay. Okay, there are some subtle changes for what you're going to see on assessment, but you're going to treat every single one of these patients the same. Okay, so I wouldn't get too caught up on what interventions are we going to do for epidural hematoma compared to subdural, because they're all kind of the same because they're having the same problems. Okay, so when we had epidural and subdural, remember the epidural is a little faster, so that can be maybe, if they see symptoms faster, they can assume epidural, but it's just for your own assessment to know that that's occurring. Everything has to come down to a CT scan. You can't just say, oh, I think they're having an epidural hematoma. You need that scan to verify. Okay, so that second one was hemorrhage. So we have intracranial pressure changes, hemorrhage, and now we have a couple other ones that aren't as common, but they're still as important. We talked briefly about hydrocephalus, I think during CVAs. It's exactly what it says. It's water in the brain. It doesn't necessarily have to be water, but fluid, essentially. Most of the time it's because the cerebral spinal fluid can't keep up, and that fluid just keeps getting bigger and bigger because the swelling keeps increasing. Okay? We treat these the same as we would any other intracranial pressure changes. We would put a canister inside and drain out that fluid. We don't want to drain too much, so that's sometimes where they'll have to be very careful and they'll have to be in the ICU, or they can give medications to diurese them. Not necessarily Lasix. They have something called mannitol. Have you guys heard of that before? Okay, mannitol is a very common one they can do for minor changes, and then if it's very severe, they can do the catheter in the brain, drain it out. Brain herniation is exactly what you think. In the brain stem it can happen, or potentially in the center part of the brain. If there's a herniation where it's swelling or pushing up on something, it can push the spinal cord down because it's herniating down and cause very deteriorating problems and actually have longer term. So if that doesn't resolve itself or the swelling doesn't come down, they can be in a vegetative state the rest of their life from a brain herniation. And that's usually from impaction on like a cement or a high-speed crash, for sure. The uncus, if you're wondering what that is, it's a small part of your brain in the middle, kind of by your pituitary gland is what I would probably think about where it's at. It's going to have a lot to do with your hearing and your visual, but that's where your nerves are at. If that is a herniated problem pushing up on those areas, it can actually cause vision changes, hearing loss, because it's swelling or herniated in that area. The third cranial nerve too, that deals a lot with like your vision as well. That's your oculomotor. So you could have problems with your pupils, drooping eyes, and potentially level of conscious changes or loss of consciousness. If you're having any type of dilated pupils, that is really bad. It has a lot to do with your like your pons and your spinal cord column. And if it's completely dilated, or you don't have any type of sluggish or even reactive state, that's a really bad state, and usually that's long-term end. Like that's usually vegetative, where they don't actually come back from those. So it's almost better to have pinpoint rather than completely dilated. Dilated is really bad. So here's the herniation. Here's the uncus that they were talking about, kind of like in the center of the brain. And if you think about your cranial nerves, they all come into one area. And that's why the swelling right there, or the herniation, can be the most detrimental, because it can affect all your sensory and your motor cranial nerves. This is your brain stem. If you have some swelling or herniation in this point, it's going to push down on your spinal cord, and that can cause problems with a lot of different sensory and motor inside your body. That's pretty bad. The central herniation, that's the one that was this one right here. That just means that it gets pushed down to your spinal cord. So this was your uncus herniation, which just means a little bit higher than your spinal cord column, and your actual spinal cord affected, excuse me, or your brainstem is more into your spinal cord column. So there can be two areas of herniation, and that deals a lot because it's the biggest part of your brain pushing down. So that central herniation, if that is occurring where you herniate down into your spinal cord column, you can have Cheyenne-Stokes breathing. You guys remember what that is? That's usually end stage, potentially death, where it's shallow, 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 and then they stop breathing. They have little apnea episodes where they go, and then they don't breathe for 30 seconds. They have a little shallow increased rhythm. Potentially non-reactive pupils, and then they're hemodynamically unstable. If they're having the central herniation, you will for sure see signs of end stage, and it'll be hard to regulate them. Obviously, if this is occurring, notify your physician. A CT scan, they'll probably be within arm's reach if they're in a neuroacute. But definitely a problem.
What do you do?
Well, it's a lot of swelling, so you can still do the draining with like a catheter, but sometimes if it's severe enough, they might not recover from it. This is a pretty severe state, especially since it goes down into like your brainstem. Really hard to regulate down there and get that swelling down. Those are the injuries you see where they're in rehab for a year or two and they're still in a coma. These people are usually in comas, and they usually don't come out of it. I mean, I knew someone that had, if you have a lot of swelling or trauma to your brainstem, or potentially like the pons or the cerebellum, that's like the lower part of your brain, usually people don't recover from that. If they do, it's very slow, and they may have the mentality of like a 5-year-old. It's not as a good prognosis as the other injuries. So here's our intracranial pressure monitoring. How we said that any type of problem, you can drain it. If it's part of the brain, they can find a way to get rid of it. And they literally are little catheters that go into potential the ventricles, epidural, subdural, depending on where the damage is at. They can drain into an actual little canister, or they can just be little screws, like they come out and they're like tiny like this. They don't actually go down into something that they can drain, or they just measure the intracranial pressure reading. So let's say we put that inside somebody, just like the screw that we're talking about. You can measure it, our intracranial pressure readings, but you won't be able to drain anything out. And the reason why they would do that is if something was very mild and there was nothing to drain out, but they wanted to monitor the intracranial pressure readings at all times. Absolutely. This is all sterile technique. If you were to go anywhere near these catheters, you have to be sterile. Even when you're changing out like the canister bag that the fluid goes into, so if it's draining and it's just sitting at, it has to be at a level point of your ear, like the tragus nerve of your ear. And if it's not, it doesn't pull appropriately. Because if you think about the gravity, it can't just flow out. It's not a suction. It's not pulling it out. But the best position is going to make it come out easier. But yes, very clean technique. You have to be sterile. Okay. You can think about infection. Very high risk for infection if you have intracranial pressure monitoring. And they have a high risk for leakage of cerebrospinal fluid. And so they do test any leakage that comes out of the brain. There can be some blood. I mean, there is some things that leak from the brain, so they don't get too caught up if they put it on their white tissue or they test it for glucose and it's negative. But if you do see that, you have to test it. But if something's leaking out, you have to look at that right away. And obviously vital signs frequently.
Like the first nursing
Well, if you're having actual for leakage, you mean?
or like all the general like hemorrhages.
Well, most of these things come in with this, Chelsea.
Yeah.
You come in with a subdural hematoma, or they're coming in with a traumatic brain injury. So most of that should be done already for you, and you should be already knowing what these are. The only thing that might change is, let's say they fell in the hospital, and you suspected that their neurological changes were changing, vital signs were changing. They would get a CT right away, and they would be able to determine all of this. And then obviously the doctor has to give you that order, so they would be in contact with you. But vital signs are for sure something you look at frequently. And if they do have ICP monitoring, yes, that's something you monitor every hour. In the neuroacute hospitals, you'll measure every hour what it is. You see it trending up or see it trending down, that's a thing that you would notify physicians.
So as a nurse, do you just want to like follow a conversation that I what?
I would be more concerned with nursing interventions and complications. What are complications that are going to happen from ICP monitoring? You have to know what a normal ICP monitoring is, and we'll talk about that. We're going to go through what exactly you would notice in that. But complications such as infection is very common. Any changes in neurological status is significant. So if your patient is talking to you and all of a sudden they're unresponsive, yes, you have to notice those changes. Any vital sign changes with these types of monitors is going to be significant as well. Okay, so I'm more worried about nursing interventions and complications. The actual process of this happening, we have to introduce to you exactly how it's occurring or how it's presented to you. It may not be as significant to you for learning for like the NCLEX exactly how something's happening or occurring, because most of the time they're going to be assessing medications, nursing interventions, and complications and how you're going to fix those. You may not know what an epidural hematoma is, but you know that it increases intracranial pressure, and you might potentially have changes with intracranial pressure and vital signs. A doctor would take it out and put it in. You would never take those out. And that usually occurs, they usually have it in for, it just depends on the injury. If they have a severe amount of swelling, they might have it in for weeks, might be 2 days. But if they're significantly thinking about keeping it in there, they probably wouldn't put it in for a day or two if it was that mild. Because that's a lot of induced potential infection that they can avoid if they don't put that in there. So those little screws I was telling you about that doesn't necessarily drain anything, they just monitor the ICP pressures. Those are things that they put in temporarily, and they wouldn't have as much chance for infection. Yes, you have a hole in your head. And just like they drill it in just how you would for your halo. Remember the halo they put in your head? Same concept. There is little holes that drain out. You have to get inside the brain. So definitely it's open. To make sure it's not falling out. Yep, they do all that. It's just like any type of tube you would put inside your body, like an NG tube. If it's 40 centimeters and now it's 20 or vice versa, you have to monitor that. And they would tell the physician if it was more than probably a centimeter or two, because you don't want that moving anywhere. I'm not sure if they suture it in. That was kind of a question too. I would suspect that they might, but I'm not sure. I have seen this before. In Rapid City, they have like a neuroacute, and I remember my first patient in the neuroacute was a guy that had ICP monitoring. It's very scary because you can't move them. If they're level on the bed, you have to make sure that you don't move them any certain way because it can affect the drainage. So these people are usually sedated on ventilators. They just have to do their best to kind of put pillows, but they can't move them that much. Or if they do move them, they have something called a transducer. Anyone heard of that before? It's like where they level, picture this, hard to explain. If their head is like this, which normally they're going to be at 30 degrees on the bed, and let's say this is their ear, because it has to be at their tragus nerve on their ear. Remember your piercings at the tragus nerve? That's where it needs to be. So what they do is they drain fluid, and there's this little thing called a transducer. There's like a pole like this. Okay? Has to be level at the tragus nerve to drain properly. Let's say you put the head down 10 degrees. Now their head's like this now. Now here's their ear. You're going to have to move that transducer a little down. Does that make sense? Or if you move the head a little farther up, you move the transducer, and that'll help it drain the fluid out. Same thing for an artery line or central line. Same thing. We use a transducer to help drain fluid or potentially cause the best pressure readings, because that's how they measure pressure as well. When you move that, you will not get an accurate pressure unless you're at the tragus nerve. Let's say it's up here on accident, and here's their tragus nerve on their ear. You might get an ICP monitoring of 40, which is really high. You would never want that. And the nurse, a novice nurse, might come in, not notice that this is really high, and she might call the doctor, and it was wrong. Okay? So the first thing he might say is the transducer in the right spot? And if it's not, you'd have to go back and remeasure it. Okay? Because then if it's down here, you might get a reading of 6, which is really good, but they might be at a 20. Okay? Make sense a little better?
How do you do it?
It's difficult. They will be intubated most of the time. They should be at 30 degrees. That's the happy number, 30 to 45. They want your head in midline. They don't want you turning on one side. They'll kind of plant towels underneath their head to make sure they're not having sore necks. They might be restrained because they don't want them, if they do wake up, pulling things. Okay, because you don't want them pulling out of ICP monitoring. when that's happening. That can be very detrimental to their health. So it's a safety thing. We want to make sure that's on there. But you just do the best you can do. Okay? They have a high risk for pneumonia, high risk for clots, and we plan accordingly with medications. And it might be a day or two, might be a week or two, might be a month. I don't know. It just depends on the person.
What do you do when they have to go back?
They have a catheter in. Sometimes they have Flexi-Seals, because they'll be on, remember they're on a ventilator, they can't get up anyway. Flexi-Seals where they put it in their bottom, and they can poop out that. Which, they're very nice if they work, but they leak a lot. But they'll have Foley catheters for sure. And nutrition, they might have an NG tube potentially, or PVN, just depending on the person. Okay, so now we talked about what intracranial pressure is. Obviously the swelling increases. Now, what are you going to see in your patients if it's increased? Because this is very significant. This is what I want you guys to know. Because this is how you're going to be able to change by not even knowing what the ICP monitor is measuring. Let's say it's high or low. These are things that you can do subtle changes to know on your patient. You could be in a med-surg in Wagner, South Dakota, or Pierre, South Dakota, and notice these changes because of a head injury, and you could know if an intracranial pressure was increased because of these changes. Okay? So it doesn't mean you have to be in a neuroacute. You can be anywhere in the world and know these symptoms. With any type of neuro, it's going to be your loss of consciousness or level of consciousness, depending if you lose it completely, if they fall and hit their head, or if they're continue getting more lethargic, drowsy. Those are things you can look for. Now you have the other spectrum of restlessness. If they're anxious and they can't stop fidgeting because they had it, let's say they fell, and all of a sudden they're just kind of anxious and they can't stop picking at things, that is something that is a subtle clue for you to be like, they weren't like this before. Why are they so restless? Nauseous and vomiting, that deals with the pressure changes in the brain. You'll see with the concussions a lot, they'll get nauseous and vomit. Altered speech, this can deal a lot with like strokes, hemorrhagic strokes. If you think about pressure on the brain, it causes these problems. And so you might see speech pattern changes, aphasia, they can't get their words out, they're slurring their words. The number one thing is the CT scan, remember? So you'll rule out a lot of these things by doing a CT scan. Pupil changes, remember dilated is bad. We don't want them to be dilated and non-reactive, but we also don't want pinpoint. The dilated is worse in my eyes. Papilledema, that's some edema around the optic disc. That's very common in intracranial pressure changes. They can tell it on a CT scan. They'll be able to look at all that. Ataxia is just when they have certain movements that they can't control. They might fidget more, or they just kind of reach out their feet and hands. They don't actually have control of it. Seizures, if the pressure is high enough. Subtle changes for someone like you and I might cause a seizure, but someone that has a history of seizures may not be as affected right away because they have seizures all the time. And so if they have a history of seizures and they're having a seizure in the hospital, we can't necessarily correlate that to intracranial pressure changes because they have a history of it. It's only for someone like one of you in here that maybe don't have a history of seizures. With intracranial pressure changes, severe hypertension, like 200s, like I told you, 200s over 100s, and they will be bradycardic. Those are symptoms of called the Cushing's triad, if you've ever heard those. Very common in intracranial pressure changes. And then posturing. Have you ever had a patient that was decerabit or decorticate? You ever seen that before? Potentially nursing home patients that have severe neurological deficits, they will still be decorticate inside the hospital or inside the nursing home forever. Like they can't actually reverse their neurological state. And we'll look at a picture of what that looks like. But if you ever see posturing, I've had a person on the ventilator. I can't remember what they were in for, but I remember I would suction them and they decorticate posture. And I was like, oh crap. Because that means that a part of the brain that's affected is so severe that it's causing this posturing. It's usually a really bad sign. So we did transfer them to Sioux Falls because any posturing is bad. I'll show a picture here. So good ways to remember the decorticate. There's C's in decorticate, right? There's C's in decerabit too, but there's a lot more E's. But decorticate, I think of C, like they're going to the core, okay? They're completely tight. They're flexing their arms. Sometimes they extend their feet, but they're tight inside, okay? Usually everything's to the in. With decerabit, they're going out. See my little E for my hands? They're going out like this. They force their hands out, and it is prominent. It's not subtle. It'll be completely tight. You won't be able to move them until you stop the stimulus that you're doing. Some people are constantly decorticate all the time, but Sometimes stimulus or like suctioning, moving someone will cause them to do the decorticate, which I think is more common, and that will cause them to go into that posturing state. If you see this, report to your physician immediately, which is what I did. It tells you exactly where it's affecting the brain. I'm not going to have you memorize that. That to me is not important. I want to have you guys know if you see this on assessment that it's bad, and you should be telling your physician. It's usually parts of the brain that are severely affected. Okay, so what are you going to see with vital signs? We talked about Cushing's triad. You will see this on the NCLEX. I'm almost certain of it. If they pick neural changes or intracranial pressure changes, they love Cushing's triad. It's just very common. It's easy for them to assess, and it makes students confused because they think about vital signs. They can be up and down, up and down. Okay? With intracranial pressure changes, you will see severe hypertension and bradycardia, and you usually will see low respirations. Okay? Don't get it confused with shock. Not neurogenic shock. I'm talking about hemorrhagic sepsis, hypovolemic shock. Remember with shock you have tachycardia, hypotension. A lot of this stuff is going to start coming together and you're going to say, I don't remember which one's hypertensive because they're all, some are different, okay? But don't try to get them confused. Okay? Increased intracranial pressure, we talked about most of these, but these are probably the ones that you should be knowing for the exam. Okay? These are things that I'm going to test over, things that you might see. I wouldn't pay too much attention to infants because we're not, we're teaching adult med surg. But with infants, those are things you can notice. Potentially, I think about high risk for like shaken baby syndrome. That's what they're looking for because a lot of the reasons is because they shake them or they fell like off the washer and dryer, or they fell off the couch. Those are things that usually occur from those. But Cushing's triad, very important. And we'll want to make sure we know any type of posturing, decreased motor function, loss of consciousness, any type of pupil changes. Those are things we're looking for. This is a really busy slide, but go through this. I'm not going to go through every single thing. Go through this when you're studying, and after you kind of looked at all your PowerPoints and you're studying, all this will really make sense, and it's all in one slide. You'll say, oh yeah, that is what we do for nursing intervention. And this is what I would test over too. I'm really focusing on your nursing interventions. What are you going to do for these patients? Okay. There aren't very many medications for the neuro part of it, or it's kind of repetitive. You see a lot of the same meds over and over again. So I wouldn't get too med heavy unless I specify, like for your medication commercials, mannitol is on there. You will have to know mannitol. That's a very common one for increased intracranial pressures. Okay. Yeah, nursing interventions is very good one to know.
You want to know a lot about what we do. You said head injury, like if there's no sedatives.
We talk a little bit about that in a bit. The main thing for pain is that since they already like in a coma or they're already sedated, they don't really need much anything. Small dosages is really good for those types of patients because we actually can further their neurological problems if we give too big of dosages. So we like to give very small opioids or small anti-anxiety meds because then they could potentially get worse. So small is key for intracranial pressure changes and head injuries. We take a break? All right, we'll start with this. All right. Okay, so we're almost done talking about the nursing interventions for intracranial pressure monitoring. But these are things that you can kind of put in the back burner for what you would think of nursing interventions. Oh, did I resume? No, I didn't. Oh, yeah, I did. I want to make sure I recorded it. We talked about the transducer, and this little device, it's an actual whole kind of device here that it drains into the actual canister. So the transducer is what keeps it level, or what it is to actually drain it. Dana. And there's a little thing down here that drains the actual fluid into. So for some nursing Alarms, it might alarm when it's half full or 3/4 full, because you'll have to change that, okay? You'll want to have 2 nurses around just to make sure that one can kind of help keep the patient comfortable if they're having problems with the movement or the changes. And it's a quick process. You want to get a new canister right on, right quickly. And it's a sterile technique. So you don't want to mess with any of that infection that could potentially get inside the patient. The alarms too, if let's say the intracranial pressure is greater, a normal is 15 or less, if you're wondering. But if something's greater than 15, it'll beep at you and say it's too high. Certain things, not just the patient itself, could make the intracranial pressure changes increase. Think about a patient coughing, or a person that's bearing down, or suctioning. You have to suction because their airway is not patent. We would still suction these patients because airway is very important, but we would limit the suctioning. We wouldn't suction on schedule ever, and we wouldn't do it just for the heck of it, and we'd keep our passes to 10 seconds or less, or if their intracranial pressure jumped to 40, we have to stop. Okay, we don't want to get the pressure too high. So those are things that you have to notice when you're actually suctioning the patient. You learn to cluster cares throughout all nursing. This is not the time to cluster cares, because too much stimuli too fast will be actually a bad thing. So if you go into your patient's room thinking you're going to do assessment, vitals, you're going to reposition them, wash their face, talk to the family for 20 minutes, turn the light on, turn it off, flush the stool. No, that's not something you want to do during this time. You might come in and get a set of vitals, do a brief assessment, obviously, to see what's going on. Come back in 20 minutes, let them come back down. The lights will most likely be off or dimmed because you don't want to cause too much stimuli. That's what pen lights are for. You can still have a little light, but not enough to blind them if they have so much light on them. Quiet whispering. When families are in the room, we have them step out, and that's when we talk, because they might start crying, and that's going to cause them to get anxious, and they might be able to hear that. Okay, so no stimuli is a good thing. Okay, and no clustering cares, because that's going to cause too much things at one time. Okay, if you're doing the activities, notice what their response is. If they start suctioning the patient and they Brady down, remember from vagal stimulation, or potentially they decorticate posture, you need to stop those activities that are causing that stimuli. Okay, so noticing what their response is. Infection, remember I told you it's an actual canister coming out of their head for the intracranial pressure monitoring. If it's coming outside the head and you're noticing any type of drainage, or it looks like pus, there could be some drainage that looks a little yellow or green potentially if it's that infected, and we'll want to monitor people for infection. Well, it's hard because they're monitoring their temperature. What is something with brain injuries that we look at or that we experience? Thermoregulation. They can't regulate their temperatures. It's normal for them to be 100.5 all the time. Okay? We usually don't give Tylenol until they're 101. Some doctors might say 102. Okay? If they are constantly in over 100 degrees, we will cold pack them and give them cooler things to get their temperature down because they can't regulate their temperatures. Monitoring white count, we'll do frequent chest x-rays to make sure that they're not having any type of pneumonia, urinary assessments to make sure that there's no urosepsis, but it's very common for them to get an infection, especially if this is occurring. We talked about the clustering cares that we want to space out our interventions. Normally, in every other thing, we cluster cares, but today is not one of them.
Really quick, what's the transducer?
The transducer was that little thing. It's like a little device that keeps it level, so then it helps it drain the fluid out. So when we talked about our bed being at 30 degrees, let's say it's this guy right here is 30 degrees, we measured at the tragus nerve of the ear, and if for some reason it's up or down, it can vary the intracranial pressure readings. So if your head is not directly in line with that, it can give you a false reading. That's why you want to make sure it's level, and that'll give you the best one. So you can move it. It's not going to hurt it. Move it up or down to where you need to be, and that'll potentially give you the best reading. Okay, so now we're done talking about intracranial pressure monitoring. Now we're going to talk about head injuries as a whole and what we can do for patients to promote prevention and promote wellness. I just read this slide last night in the lab because I feel like everyone in here should know this slide. Okay, we know to avoid drinking while driving. We know to not increase our speeds to the point excess the speed limit. Making sure that you're wearing your helmets when you're wearing or doing any type of activity like a football or skiing, protective gear. We want to protect our brain in the best way possible. To me, these are no-brainers, right? I mean, to me, I feel like this is stuff that isn't really, it's all common sense. Avoid dangerous risk activities. Don't go skydiving if you don't, want to have the consequences of the problems that could occur. Requiring training. What they're saying there is that, like, let's say you have to bungee jump and you have to go through a set of training, there might be potential risk for that, like a head injury. Okay. Environmental hazards for the elderly. Looking at their home environment. How many older people live on second floor? Do they have loose rugs everywhere? Do they have appropriate railing inside the bathroom? Those are things that they're looking for the elderly, because that can prevent falls. I think this is in the sim lab, and I don't know if we're using it, if you have simulation yet. Have you seen this? No. I went in there the other day and I said, hey, this is one of our slides. So I don't know what you're having for sim, but it's something related to the slide. So if you want to have that before. But these are things that we look for in the first 24 hours after a head injury, or things that you might suspect for potential intracranial pressure changes, or concussion, or potential damage to the brain. Like I said, loss of consciousness. That's going to be the most common thing for you to go get evaluated, and they will do a head CT to rule out any type of problem. If you are having increased drowsiness or your headache that is so severe, not just a mild headache, but very severe headache, they're constantly vomiting 24 hours after, that is indication to come into the hospital or come into the ER. Because if the head injury is that severe, you need to be evaluated at admission. You have to come in and get admitted. Okay? Okay, so we're back to our head injury and what we're going to look for on assessment. When they come in, if you work in the ER, you'll see this first. You probably won't see this if you work up on the med-surg floor. But when we're getting a history of their general reason why they came in, we need to know, did they lose consciousness? That is very important. If they come in from a Little League soccer game and they got hit in the head with the ball and they actually lost consciousness, we need to know that. So we will ask the family if the patient does not know. Most people don't know if they're the one affected. So ask mom and dad, did the kid get hit in the head? Did he get loss of consciousness? And they'll say yes or no. How long? Was it 30 seconds? Was it 2 seconds? How long was it? That's important as well. Potentially, is alcohol involved? Because now on top of a head injury, now we have to deal with the alcohol as well. And sometimes people have withdrawals from alcohol if they are actually alcoholics or they're drug abusers. Now we have to worry about that on top of the injury. Okay. Did they have a seizure? Some children, I feel like seizures are more common in the smaller children because their heads are so big. And I feel like if they have really severe concussions, they will seize. And that's where parents get really frightened because they'll see them foaming at the mouth, they'll turn blue. And we have to know that and how long the seizure lasted. Most parents won't say, oh, it lasted 2 minutes, but it might feel like 5 years when it was only 30 seconds. Okay, so we have to be doing the most objective assessment possible. Okay. Allergies to seafood just means the CT dye. Whenever you do a head CT for any type of head injury, they'll induce that dye inside your body. If you're allergic to seafood, you can potentially have reactions from that. It's the same dye as iodine, what it is. Okay. Like we said, the intracranial pressure changes. If you have severe hypertension, you might potentially have intracranial pressure changes. Bradycardia is another common one. We'll look at your ABGs and how you're breathing. If there's any hypoxia to the brain, we'll look at those as well. Remember, if we have really severe intracranial pressure increased, your carbon dioxide will shoot through the roof. We can look at capnography. You guys remember what that was on a ventilator? They put that little thing at the end, and it tests how much carbon dioxide is being expelled through your mouth, the little device. They can also do it through ABGs, but ABGs might be a little more invasive if they've already had them intubated. Very non-invasive to do the carbon dioxide monitor if they're already intubated. Okay? ABCs is always going to be the true and foremost thing for any brain injury. We will have a cervical collar probably on them to keep cervical spine, but if their airway is not intact, we need to look at respirations, looking at their SATs, how are they breathing, and how often. Okay? If their neurological change is diminished or their reflexes get worse, we could potentially see them getting degenerated from that aspect, where they're not actually having the reflexes that they normally would, and they've lost total consciousness. Okay, Cushing's triad, remember, it's going to come back threefold. There's so many times that it comes up on these PowerPoints, but it's very important because if we notice that they're having severe hypertension, bradycardia, and decreased respirations, we can assume potentially that they might have problems with their autoregulation, and it's a severe case of a head injury. So if you see these vitals on assessment, That is something you want to notify your physician, which if it's in the ER and they're initially getting these vital signs, they will know it already. But sometimes it takes a few hours for this to get into effect. They might be up on the floor already, and you can call the doctor. Okay, Glasgow Coma Scale. We talked about it a little bit on, I think it was peripheral, maybe the spinal cord injuries. But I'm not going to have you memorize the scale, but there might be a question on the exam that says a GCS of 7. I want you to know if that's good or bad, okay, or a GCS of 10 or 12. Knowing that the higher the scale, or the number, the better off they are, okay? So that'll tell you a little bit about how they're functioning. You may not know exactly, according to the scale, what it looks like, but you can tell if it's high or low, okay? Pupil changes, pinpoint, remember their brainstem or their pons is affected. The worst off is the dilated, or the ovoid, like an egg-shaped. It literally looks like cat eyes. If you see that on assessment, you need to notify your physician as well. It looks like this. It's completely open instead of like this. This is normal. They will look like cat eyes. And it almost looks like their pupils are draining outside of itself. It's not keeping intact with the circle. If you see that, that is a really telltale sign for increased intracranial pressure. So you can tell all these little symptoms by not even putting a catheter inside their brain and measuring intracranial pressure. Okay? These are subtle things you can look on assessment and know right away. Okay? Asymmetrical pupils, I have never seen this before, but I have a feeling that if this were the case, you'd have pretty poor prognosis. If one was small and one was large, okay? It's telling me there that your regulation in your brain is none. You're not doing anything, okay? Or if your pupils are completely fixed and they're not moving, it might be a point of vegetative state. It might be time to get family involved to make decisions. Okay? We talked about the posturing that you might potentially see. Yes, it indicates severe brain injury, but let's say it's a new patient, you don't know much about them. If they come in already with decerebral or decorticate posturing, that is a very significant sign that you have severe brain damage before you've even done a head CT. If they're potentially having speech alterations, this deals with your stroke as well. We have to do a CT scan to verify exactly what's happening and what we need to fix it. If the headache is severe enough after a concussion, remember a very severe one, that can mean potential pressure changes in the brain as well. A mild headache we're not as concerned about because they did get some head trauma. They might potentially have a small headache. But severe is where we get to the point where they're 10 out of 10 pain. The halo sign, remember that on the tissue? They have the yellow ring around, and usually they just put it right on the tissue if it's draining, and you'll see it right away. Okay? Meningitis. What's meningitis? They're infection in the brain, but what are the signs you're going to see? Nuchal rigidity, which is your stiff neck, or you'll see sometimes when they lift the legs up, the neck will come forward. It's like a reflex. I think it's not Babinski's. I'm going to brain fart, but it is. If you look at the questions on your guys' like review, like that one I put on TigerNet, there's that sign on there. I can't think of it right now. I know, I can't, it's like, I'm going to have a brain fart. I'm not sure which one it is. But there's a sign that says when you put their knees up, their head will come forward. Brudinsky? Yeah, not Babinski. Yeah, it's that one. And that can be a sign that there is meningitis present, which would be an infection in the brain. Okay. If the severity of the infection of the brain or the increased cranial pressure was severe enough and they have problems regulating their body or their audio regulation, you might have to get family involved because this can be very psychosocial effect on any family member. The patient might not be able to talk for themselves, so the family has to come next. And so we have to make sure that we're there for the family and giving them realistic expectations. If there is a severe part of the brain affected, and we know from taking care of the same patients over and over again that the prognosis is not great, we need to let them know that. Because I think that's the biggest problem with brain injuries is that families get false hope and they think they're coming back and there might be no chance of revival. Okay? So I think doctors have a hard time with this because they see the patient for 10 minutes a day. We see them 23 hours a day. Okay? So we want to make sure that we're giving realistic expectations. Because I feel like if you don't, they're constantly going to say any type of improvement. They may think decorticate posturing is movement, and they have never moved in 2 years, and they, oh, they move, that's good. No, we need to let them know that that's an abnormal posturing, and that's not a good prognosis, okay? So I've had times where they've had reflexes, and the family thinks that's a good sign because it's a move. They actually moved from where they were, and I let them know that that was not voluntarily, okay? Because they need to know that. Okay. Non-surgical management of the head injury. We are going to be looking at the whole picture here. ABCs is always a priority. They'll probably get ABGs done, initially more often, and then as they become more stable, less often. Making sure there's no signs of hemorrhage. They might get some bleeding tests done, a CBC to check for infection as well. That'll show your white blood count and your hemoglobin. Electrolytes, they have a hard time regulating their electrolytes because of the fluid inside the brain. And so they could potentially have electrolytes imbalances. If you remember back from the fall semester, they can have diabetes insipidus if it's a pressure on the pituitary gland, or potentially SIADH, and have different electrolyte imbalances there. Assessment and vitals are going to be done very frequently. You thought every 4 was a lot. They do assessment vitals every hour at the most, or at the minimum. They at least do them every single hour. I remember when we were at the neuroacute, we did them every 30 minutes. So they usually have swans, which are central lines that go inside the heart. They measure blood pressure, temperature, every single vital sign all the time, and they would monitor those and write those down every 15 minutes to 30 minutes if they were severe enough. They'll for sure be on a telly. They'll always have the cardiac monitor to make sure we're monitoring for any type of dysrhythmias. Fever control, remember how I told you most of them are 100 or more all the time, and they will do cooling blankets, potentially like sponge baths, or not put tons of blankets on them, even though families will want to keep them warm, but actually you'll want to keep them fairly naked. Like you don't want to have tons of stuff on them. Remember we talked about positioning on our intracranial pressure monitoring? We want to make sure people are 30 degrees. We don't want them 90. We don't want them supine, okay? We want 30 degrees, give or take 15 degrees. Usually 30 to 45 is a good range, okay? And that reason is because of the intracranial pressure changes. If someone is flat, their intracranial pressure will increase. If they get raised up, their pressure will decrease. And that has a lot to do with it draining down. Think about your venous drainage can go back down into the rest of your body, and that can cause the pressure to decrease. We don't want to move their head more than the neutral spine. We want to keep it directly midline. We don't want them turning or severely opening. We like to keep them straight. And Chelsea made a good point. How the heck do you do that for a week or 2 at a time? It is very difficult. They will be sedated. Okay? We'll do the best we can to keep things elevated, feet elevated, putting small pillows underneath the sides of their bottom and their back. But yes, they do have problems with infection, skin ulcers, DVTs, pneumonia, very common. Let's see what else here. Pulmonary ventilation, we talked about carbon dioxide levels being very high. We can hyperventilate them, making the CO2 levels back down to normal. Okay. Carbon dioxide is a very potent vasodilator, and that's going to cause the swelling to increase. If your vasodilator keeps increasing, you will potentially die because your swelling is so severe. If a carbon dioxide level is 70, that is really bad for your patient that has the intracranial pressure that's really high. Things that can potentially increase intracranial pressure, suctioning as well. These are things that your patient probably will have problems with their airway. We have to suction our patient. We can't just say, well, their intracranial pressure is 40, so we can't suction the patient. Let's say it consistently stays that way. Because what is our quality of life if we don't have an airway? None. Okay, so we have to say 2 really severe problems and trump which one is more important. Okay, so we might have an intracranial pressure of 40. If it stays like that for a long time, that's obviously a huge problem. They might have to have a craniotomy to relieve that swelling in the brain. But let's say you were 10 to 15, maybe 20 occasionally, and they started coughing a lot, or they had a lot of stimulus and they were 40s. Obviously, then we could wait a little time to get them back to their normal or get them back to where they were, and then we could suction. But if they're always 40, the doctor has to know that.
If they had you needed to suction, like raise the head of the bed while
Yeah, we could do small changes like that. They are going to get something called mannitol, which will dry them out, because it is a diuretic. It makes them pee it out. And so if you're drying someone out more, the secretions increase. So it's not like we can give them 2 liters of fluid. Because honestly, we restrict their fluids. We don't want any extra fluid on this person if we can prevent it. So we have small things we can do like that, Dana, but for the most part, we can't do too much. So if it's consistently in the high range, they might have to have a craniotomy because they're showing us that they can't regulate their pressures of their brain. 40 is really high. That was kind of an extreme example, but it does get there if they start coughing a lot or if they're getting suction severely. Because of the diuretics and they have potential for pneumonia, we will do physiotherapy where we actually percuss their lungs, or they might have potential, they can do like the forced coughing if they aren't actually coughing anything up. But potentially that could give us more intracranial pressure, and now we have another problem. So airway always trumps intracranial pressure unless you're the reason why the pressure is high. Does that make sense? Because we can actually stop the suction or stop the stimulus if we're the reason why it's causing it to be high. If it's a severe traumatic brain injury, we would suspect that they'd be on a ventilator because they probably can't regulate their own body. We could potentially ask the family. This is something that we would not do, something a physician would do. We wouldn't just say, hey, it looks like your family member's not going to make it. Should we contact the organ donation? No. You want to get slapped in the face and get changed to a different patient, that's the first way to do it. You have to be very in tune to their feelings. Okay? There is appropriate times to bring this up. Sometimes a chaplain can bring it up. If the person is pretty much declared dead, but they're on a ventilator, that is the only way you can donate your organs. Okay? Just because you have it on your driver's license that you're an organ donor, that doesn't mean anything until you're on a ventilator and those actual organs are being perfused. Okay? Perfect example. Hate to say it, but traumatic brain injuries happen in people that are young. These are the perfect people to get organ donations from. If you can get the people or the family involved to give you those organs, someone can be severely helped because of their heart is only 20 years old. Their lungs are only 20 years old. It's not the problem in the accident. Their heart and lungs are fine. It's their brain. Okay? Obviously, you don't do brain transplants, so it's not a problem, right? So these people are very targeted to get their organs donated because they're most of the time on ventilators and they have very young, healthy organs. Hate to say it, but it happens a lot. Okay, I think these are like the 3 meds you have to know for head injury. There's not very much. I would focus the most on mannitol because steroids have shown some improvement getting the swelling down, but it is not as good as mannitol. Mannitol is your #1 over and over again. Mannitol is one of those medications that you don't have to be skilled to give it, but you have to be aware of how to give it. It's one of those meds that has to be cold before they're given, because if it's in room temperature, it'll crystallize, and it'll go all, I've actually given this before, and it was at room temperature for 20 minutes, and started crystallizing down the tubing, primary tubing. So you give it pretty fast, usually 10 to 15 minutes. Anything longer than 20 minutes, you start to crystallize. Okay, so you can't, I think the reason why that happened was we were gonna give it, but then something happened where we couldn't for like 5 or 10 minutes, and that's how detrimental it was. It goes from refrigerator to patient right away. Okay. Another thing with this is it cannot touch normal saline. It will crystallize, which is really weird because everything's compatible in normal saline, right? Not mannitol. So what you have to do, your little piggy on your IV, how it goes like this, you draw back blood to make sure all the blood is inside that canister, and then you hook up your mannitol. Okay. Even that 2 cc's or 1 cc of normal saline in there will make it crystallize. And you don't want that going into your patient. So a very severe medication, you probably wouldn't give it through a peripheral line. You give it in a PICC line or a central line because you want a nice big catheter. Okay.
So if you do crystallize, you stop it, right?
Yes, do not give it if it's already crystallized. You'll have to get a new one, and we stopped it. But they said it's normal to like see little like shiny crystals at first, but it's only when it starts to harden. So I was kind of scared giving it to my first patient I ever gave it to because I thought I was doing something wrong. But the nurse that had been there for a while, she goes, no, that's normal. It's only when it gets hard. I said, okay. So we gave it in like 10 minutes. It's really fast. Not a push. It's in an actual little bag. It's a small, tiny bag. It just goes in over 10 minutes. It's pretty quick. It has to have a filter. Makes sense, right? If it crystallizes, that filter will help some of that debris in there. But yes, a very potent medication, but it works wonderful. Makes them pee, right? It's a diuretic, so you'll see increased urine output. That's a good way to measure it, and then you'll start seeing their neurological function come around because they're actually getting swelling off their brain.
And something happens and it starts to crystallize, can you throw it back in the fridge? Like for person?
We didn't because they, like our pharmacy just told us to get a new one. But it probably has something to do with the tubing. You have to, well, first of all, you have to get all new tubing. That'd be the first thing. But since you already punctured it, if you went back in the fridge, it'd be exposed.
No, I meant like before, like something happened and it didn't get put up before.
I'm not sure. I would, to me, I would think they just get a new one. But yes, it would make sense if they went back in the fridge and it went back to its normal state. But I would just get a new one. It's probably a really expensive medication, though. I would agree with that.
When you say that, she's not.
Yeah.
After you draw back the blood or how?
Yes, because like what you have is, you think about your IV. Your IV going into your body, like say here's your cancer. Then you have your little piggy.
Yeah.
And then this is normal saline flush goes in there, right? So what you do is you pull back blood, so there's all blood in this little piggy. So you literally will keep the blood there, and then you'll hook up your primary tubing to this line. So now you primed it with all mannitol. It's going to go directly into blood. It's not going to touch any normal saline at all. Okay? Okay, I knew you were going to ask that. Okay, so then what you do after you're done with the actual infusion, you will have mannitol inside this line, and what you'll do is you'll draw back more blood, and so there's blood inside the canister. Now again, when you're done, because the infusion is already in there, you unplug the mannitol, draw back blood, and then you can push the normal saline in, because now you have blood instead of mannitol in that little tubing. You know what I'm talking about? Does that make sense? Jess? Still confused? Right, not a flush. Yep. You wouldn't use the normal saline flush. It would be an actual empty syringe. You pull back the blood when the transfusion was already in and done, and then you could flush it with saline, because now you have blood instead of mannitol.
You put it in.
Yep, you should be able to, and actually it's preferred. Peripheral line, you could if it's a last resort, but they're going to most likely have peripheral picks or a central line. The guy I did on had a pick, and that was fine. It was a central line. Okay, Lasix can also be used. Mannitol is our first one, but you can use Lasix. Think about how Lasix and mannitol works. It's a diuretic, but mannitol focuses more on the actual brain swelling instead of the rest of the body. So Lasix can be used too in regard to helping that other mannitol out. Okay, those are our 3 meds. There's not really that much. Okay, so that's kind of a good thing for people that hate meds. But most of the time, it's nursing interventions and figuring out what you're going to need. Always, 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 you'll have a Foley in these patients. You have to do strict diagnose. You have to make sure you're doing exactly what's going in and what exactly is coming out, because you want to make sure that the brain is actually getting rid of fluid.
So with this glucocorticoids, not for ICU, for
You can use it for brain injuries because it helps with the swelling, but it's not shown as effective as mannitol. That's why it says here it's shown to have little or no benefits with intracranial pressures, but it can help with the swelling. It's just not as effective as mannitol. They give it, but they may not be as good. Opioids is pain. Remember we talked about with Katie, she goes, well, how important is it for us to know pain control? The biggest thing with pain control is that we are going to give these people opioids, even though they're the strongest medication, but very small dosages. Because these people are already in coma or comatose state, we don't want to severely get them to the point where they're so lethargic because of their pain meds, because we're not helping the fact. We want them to wake up again. We might give them mild sedation meds and mild anti-anxiety meds, just so it takes the pain off if they're having any pain. Most time you use it because they're anxious and we can't have their intracranial pressures increase, so we give them an anti-anxiety so they don't have those pressures shoot through the roof. We want them nice and easy and nice and relaxed, because if they're moving around, the pressure is going to go through the roof. We don't want that until the swelling goes down, which it might be a day, it might be 2 weeks. Just depends on the patient. So the key is giving small dosages, and you can give them together, like giving Ativan with morphine, but giving very small dosages of each. And so now you're fixing 2 problems, but you're not giving so much medicine to cause them to go into a more lethargic state. Paralytics, we don't usually like to give these. Usually it's just a bolus to get them started, so then they can actually get intubated and get calmed down. You would never give paralytics without sedation meds. If you were ever paralyzed and you weren't actually sleeping or sedated, how horrible would that be? couldn't actually move, but you knew everything that was going on. So if you're giving paralytics, you have to give some type of sedation, like propofol, which is a sedative medicine, or maybe Versed or something to calm them down. Okay? So those can be given if the person is thrashing around because they're constantly at a threat of maybe getting their tube put out or central line, tele. There's so many cords on these patients. We can't be having them thrash around. Some people, it takes a lot of medicine. Sometimes it takes a little bit. Just depends on each person. If they have a seizure, this is more related to the secondary part. It's not necessarily the primary injury. But seizures, if we do give Dilantin, how do we give Dilantin if they're having a seizure? IV. You'd never give PO. They might be getting something, well, NG, because they probably won't be swallowing. But say if they were getting something through their NG every day for seizure prevention, we'd be checking Dilantin levels, right? Because that's something you don't want to give too much of, because then they can have cardiac effects. Tylenol, if their fever is more than 101, we usually say 100.5 and less is usually normal for people with head injuries because they're always high. I've seen people 100 all the time. You never get them under 100 because of the autoregulation. Sometimes if they're thrashing around so much and we cannot get them to calm down, we can give them or put them into a barbiturate coma, where basically we're giving that sedation or something to calm them down, and they stay calm for a long time. We put them in this coma. Okay, this is something we induce them in. They may be completely comatose because we put them there. So that's another thing you have to tell family members. The reason why we're giving all these meds is to make sure they're safe and making sure they're not pulling lines out, making sure that their intracranial pressures are low. They may not like it, but at the same time, we have to know initially that their swelling is coming down rather than their prognosis. The swelling will kill you if it gets high enough. Okay? The more stuff they do to stimulate it, the worse off they are. Propofol, do you guys remember Michael Jackson, how he died? Propofol was the medication he used. Okay? 99% of the time, we'll use this in the ICU for sedation. I don't think I've used anything else besides Precedex. Propofol is the #1 drug of choice. I give it right away, they're asleep. It's a wonderful med. Okay? So they give this medicine and they sleep right away. But yes, that's how they'll use it to calm them down. If they're on the ventilator, they'll for sure be getting this medicine. Okay? Again, these meds aren't maybe as important as the mannitol, but if you think about how people come into the hospital, it's not because of their brain injury. We're treating their secondary symptoms. They have to be calm. They have to be not thrashing around the ventilator. These are medications we would give to those people. Tylenol, no brainer. If their fever is above 101, we'll give Tylenol. If they're having a seizure because of the swelling, we will give Dilantin.
Why was Michael Jackson?
Exactly. It's only an IV medication. Money buys everything. So he definitely was getting it for whatever reason he wanted it for. But I don't know if it was induced or if he got too much.
That's sleep aid.
Which is ridiculous. Propofol for sleep aid is, we like monitor vitals every hour on propofol if they're on a propofol drip. He may have given himself like a minute amount to like a bolus, but still, one little bit too much, which he died from it obviously. But even just a little overdose can kill someone with a respiratory depression. So I don't know what doctor would ever prescribe that. I don't care how much money you put in someone's face, because that to me is just like a death sentence, literally. It was. Okay, so fluid and electrolyte management, we talked about diabetes insipidus and SIADH. I'm not going to stress too much on this on the exam. We've already learned about this. We've already tested over this. I want you guys to know that fluid electrolytes can be affected, and this is what we're going to look for. But again, I'm not going to go back down to Unit 3 of last semester, and we're going to start talking about urine osmolarities. Okay, we've learned that already. I want to focus on what's important now, because it's what we're learning now. But keep in mind that people that have this affected, they might be pushing up on the pituitary gland, which is important for regulation of fluid and electrolytes. And so that might be a reason why they're having these problems. Okay? But I wouldn't focus too much on this slide, just to kind of show you things that can happen from this. Okay, like we talked about, they're not going to be eating. They're most likely going to be on a ventilator. We can do NG tubes, but there is a potential risk for maybe basilar fractures. We would never put an NG tube into someone that had a risk for a fracture in the brain. They might stick straight to OG tubes, where it goes in the mouth, or they might just go get a PEG tube, the one that goes right into the stomach right away. Yep, PEG tubes can be reversible. They might start CVN, the nutrition through the vein first, That might be a good thing they just get going. Peg tubes can take a week or two to that's probably not going to be the first priority if they have brain swelling, because that is a surgery. And so they might wait a week or two on peripheral nutrition before they get that inserted. So during that time, CVN might be their first line of choice. We are going to restrict fluid. We don't want to give too much because that will cause more swelling and more fluid. And we're giving diuretics, so it's going to push it right out anyway. We still like to keep them hydrated, but to the point where there's a happy hydration equal. Okay? They might have trouble swallowing. We won't test for this until after their brain injury is more stable, and maybe they're off the ventilator and their swelling is completely gone. So that may be something in the future that we look for swallowing tests. With any type, we looked at this in CVA, but the best thing to introduce people with is soft foods, potentially pureed, semi-soft. We would never start with thin liquids. So don't give them a drink of their water at the bedside if they've never been evaluated after some type of brain injury, because you might have them choke and now you have aspiration pneumonia. Speech pathologists will always be the first line of choice. You will never have to do the first initial swallow study. That'll be a speech pathologist or a speech therapy treatment. Okay? And then you will proceed after they give you the recommendations. A little bit longer, guys. Hazard-free environment. We want to make sure that the least possible stimulus is possible. We don't want to give them any excessive activities to do if they can't do them. Making sure it's a quiet, nice environment where there's not a lot of noise, not a lot of light. Explanation of all procedures. If the person that's actually getting the treatments cannot understand you, family members, it's still good to let them know what you're doing. But if you don't, they might become scared or they won't trust you as well. Seizure precautions, we think about the padded side rails. They do have a high risk for seizures, so low position of the bed. We potentially would like a little bit of raise in the bed. 30 degrees is a good number. No restrictive clothing, and then making sure that you're monitoring them frequently. Their Dilantin levels, ever making sure that you're looking at medications they're giving. We don't like to do restraints if it's possible, because that's a more stimulus. If they're getting restrained down, that might cause them to have more intracranial pressure changes. But sometimes you have no choice, because you have to protect the patient's safety. We would turn to sedation medications first before we restrain somebody. But if that's not working, or you're constantly worried about them waking up, restraints might be your best option. Bail beds are usually for kids. Those are like the nets that they put around kids' beds, or like a crib. You've ever seen those before? I have seen an adult in there one time because she kept crawling out of bed. And it was like she was in a crib. But yes, there is times where you use a bail bed. We talked briefly about this for the intracranial pressure monitoring. They're called burr holes. It's actually screwing the little holes inside there where there's right through the skull. If you have your intracranial pressure catheter, they'll go inside the brain and it'll come like a little tubing outside and drain into like a little canister. Okay? It's just like any other, it's like a Foley catheter for the brain. Okay? I know it sounds ridiculous, but it literally is as simple as that. We just have to make sure our positioning is appropriate, making sure the level of transducer is appropriate, and making sure that the drainage is not looking abnormal. Okay? I'm sure nurses that work on the neuroacute floor probably don't have as much fear as we do because they deal with so many of them. But it can be fearful at first, especially for an unstable patient. Epidural and subdural catheter, those are the same things. It's just those have a less risk for infection because of where you're actually putting it. If you think about inside the ventricles that's deep in the brain, you're going to have higher risk for cerebral spinal fluid leak and potentially more infection. The screw I told you about, it doesn't actually have a catheter that drains all the way out. It's like a little thing sticking out this far, and it can measure your ICP monitoring, and that's all it does. It does not drain.
Why would you want?
You might have a mild swelling, and they just want to monitor so it doesn't get worse, but they can't actually drain anything because there's not enough swelling for it to drain. And so that can connect to a catheter, but they might not have it on there because it's a less risk for infection. It's just they'd have to change the cap. A doctor would have to take them to surgery and change the cap and put the catheter on there. So it's not as invasive, I guess, a better word for it. If it's severe enough where we can't control the swelling with our canister and our catheter, we have to do a craniotomy. We have to take a piece of that skull off where they're exposed and let that part of the area breathe, or let it sit there so it doesn't actually cause so much swelling that they die. So craniotomies might be a problem or an intervention that they might have to do and it's a last resort. You wouldn't just start with the craniotomy. You start with the other problems or the other interventions first. Okay, health teaching. Potentially people that come in might need rehab, depending on how severe their injury is. They might be there for a week, might be 6 weeks, depends on each person. They might have personality or behavior differences after they've healed completely, completely to the point of going home. They may not be the same person they were to begin with. So it's always good to tell the patients that they might have personality differences. Post-concussion syndrome, that's a syndrome where you might have problems for years on end because of a really hard blow to the head. They might have headaches for the rest of their life because they maybe triggered something in the brain that is causing them to have those problems. They might have some memory loss, or potentially they might have some exacerbations where it might occur after the effect. Okay, so they might go to the hospital, get checked out okay, but they're still having small headaches for a year or two, okay? Especially if you get hit more than once. If you're a football player or hockey player and you constantly are getting hit. Okay? Then we always find support groups or some type of support for these families because they do need a lot of psychosocial support. Okay, let's do these questions quick and then we'll go. I'm going to switch over here. We'll see if we can see these questions. We'll go through some of them. The nurse is caring for the client with an increased intracranial pressure. The nurse assesses which of the following trends and vital signs. Which one is the rising intracranial pressure? You can't click. You don't have to just shout because it's not working on that side. Which number looks appropriate? 2, okay? Remember Cushing's triad? You're going to have an increase in blood pressure, decrease in heart rate, and decrease in respirations. And because of autoregulation, they won't be able to, or thermoregulation, they won't be able to do their temperature. Okay, what is a normal ICP monitoring, or ICP per person? Oh, sorry. What is the most concerning one? The highest one, right? A normal one is less than 15. We like to see it less than 10, okay? But we do allow up to a severe injury, 10 to 15. But if it's greater than 15, we start worrying about intracranial pressure changes. Right, right. 0 is considered normal. We like to see 0. Like you and I probably would have like a 1 or a 2. If we cough, it might go up to a 7 or 10. But it goes right back down to 7. The nurse is planning care for the client with ICP monitoring. Which of the following interventions is contraindicated in the plan of care? Which one is wrong? Why is 3 wrong? Tragus, right? The central part of the ear. Okay, so simple as that is small, little smart. They usually have like a level that goes right to the tragus. We don't just visualize, oh yeah, that looks good. They actually have a little level that goes through your ear and they measure it completely to the transducer. So that's that little thing right here. This thing that measures right to your tragus. All it does is it keeps it level so it has the best part of drainage and the best intracranial pressure readings. That's what that does. The nurse is positioning the client with intracranial pressure, probably supposed to be increased. Which of the following positions does the nurse avoid? Right, you want to have midline, neutral position, 30 to 45 degrees. The client recovering from head injury is arousable and participating in care. The nurse evaluates that the client understands measures to prevent elevations in intracranial pressure if the nurse observes the client doing which of the following activities. Sorry, there's something going on. So which one is right? Right. What does that have to do with your carbon dioxide? It's going to blow it off. In these patients, they have increased carbon dioxide levels. If they're blowing off appropriately, they can lower the intracranial pressure by keeping your carbon dioxide levels lower. Isometric exercises are like planks. Have you ever done planks? Think about how you're like grunting during those, like, oh, trying to like hold your breath kind of thing. You don't want to do those type of exercises. Blowing the nose and coughing will increase your intracranial pressure through the roof. Okay, so those are things we'd avoid. The nurse is providing care to the client with intracranial pressure supposed to be increased. Which of the following approaches may not be beneficial in controlling the client's intracranial pressure from an environmental viewpoint? Right. We don't want to cluster cares. You've always been taught that, but for this, you do not want to. The client was seen and treated in ED for treatment of a concussion. The nurse evaluated that the family needs reinforcement of the discharge instructions if they verbalized to call the physician for which of the following signs and symptoms. They need reinforcement if they call the physician for any of these problems. Which one would they need reinforcement? Right. Is minor headache normal after concussion? Yeah. Yes. If it's severe, that's when we would suggest them coming in. Everything else, they would have to get, they would call the physician normally if they have those after a concussion. So those are showing signs of increased brain injury. Right. The nurse is caring for the client in ED after head injury. The client momentarily loses consciousness at the time of injury, and then they regain it. The client has now lost consciousness again. The nurse takes quick action knowing that this is compatible with what?
Epidural.
Epidural, subdural? Which one's faster? Epidural. That's the one that takes really quick. It's right on initiation of injury, and it could potentially be harmful to their legs. Sorry about the layers.